Ding. Very good. So again, we are at the webinar Palliative Rehabilitation for People with Incurable Cancer. And this session will be available on the IPT-HOPE website, and you'll be able to revisit or share it with your colleagues afterwards. We would like to keep the questions for the end of the presentation, so you can write those questions that you have currently and write them on the chat box for now. And I'm honored to introduce today's speakers. We have here Dr. Guru Brigitte Stene from Norway, and also Dr. Joe Bailey from England. So thank you. I'm really grateful that you're here today to share your expertise for this really important and sensitive topic. So here I leave the place for you. Thank you.
Thank you so much, Helena, for that lovely introduction. Both Joe and me are very delighted to be able to speak to you today and to have this webinar. I will just hang on a second. I'll have a little presentation of both of us before we start so you can see us. So as Helena said, my name is Guro, and I'm an associate professor at the Norwegian University of Science and Technology in Trondheim, and I also have a position at the University of Bergen for this particular project that we're speaking of today, INSPIRE. And I am a physiotherapist, and my expertise is in cancer rehabilitation and palliative care and exercise oncology. So my research has been focusing on multi-modal interventions, including exercise and nutrition in cancer and in palliative care. And I'm happy to see that we have Dr. Joe Bailey here as well now. Will you introduce yourself, Joe?
Hi, yeah, my name's Joe Bailey. Like Guru, I research in palliative rehabilitation. Also interested in models of care and multi-professional care, and at the moment working on projects relating to assistive devices in palliative care. I'm very happy to be here. Sorry I made Guru a bit afraid by arriving a little bit late to my laptop.
I think you're right now, so we'll start.
Yeah.
So in this webinar, Joe and myself will try to give you some insight into the INSPIRE project, which is a large EU-funded project currently going on in several European countries. INSPIRE stands for Integrated Short-Term Palliative Rehabilitation in Incurable Cancer. And in the next hour, we will try to give you some background knowledge about palliative rehabilitation and why we started the INSPIRE project. I will also show you some of the first work in the project on how palliative rehabilitation is, or you might say isn't, integrated into healthcare systems across Europe. Do you want to say something, Joe, about your presentation, or should I just say it?
Yeah, you just go ahead and then I'll join in.
Joe's presentation will outline the rationale, the development, and the evaluation of the INSPIRE trial, which is sort of the main component of the project, including the palliative rehabilitation intervention and how that was developed, which is now being tested in this multinational randomized controlled trial in the European partnership countries. And INSPIRE also works to improve equity in trial participation. So we will just briefly go into that in the end, and then hopefully we will have some time for some questions and discussions if anyone wants to participate. We firstly want to acknowledge and thank Professor Dr. Matthew Maddox, which is the scientific lead of the INSPIRE project, and all the other members of the INSPIRE project for contributing to various contents of this presentation. So a little bit of the background for palliative rehabilitation and the INSPIRE project. We know that cancer is a major cause of illness burden. It's also highly associated with loss of function, disability, and death. And why is this so? Maybe we just think that cancer is an illness, and you might not be aware of the major functional limitations that people with incurable cancer live with. But we know that 1/3 of adults need help with personal activities, and half of them also need help with domestic and leisure activities and getting around. So we also know that disability in daily activities is closely related to unplanned admissions to hospital. So with the advances in life-extending oncology treatments today, people are living longer with their illnesses. And so they may experience more disability, which reduces their quality of life. And we know also many of these people lived in European countries, they are over the age of 65 when they are diagnosed. And many of them may also be contending with multiple long-term conditions, multiple comorbidity, and the effects of aging. So what is the reality here? We know that loss of function is rated as one of the most common unmet needs among people with incurable disease. And basically, we also know that people with incurable cancer want to live as normally as possible. So considering the illness trajectories for these people, which you can see presented in this figure that I have here in this presentation, and it underlines that the prognosis of patients with incurable solid cancer is unpredictable. Some patients will benefit greatly, and others may not at all benefit from the treatments. And many patients with incurable solid cancer still die within months of being diagnosed, and others may live for considerable time. So we've seen that from research and multiple trials that confirm that it's of early supportive and palliative care, alongside the routine cancer treatments for patients with incurable cancer. We've seen that it improves quality of life, it reduces burden of symptoms, and can lead to longer survival. Yet, as we talked about the other slide, loss of function with incurable disease remains a major societal challenge, as we know that loss of function affects almost every person with serious illnesses. And it also affects the people close to them, their relatives and carers and others. So in this context, the focus on optimizing function in cancer care should be holistic, aimed at enabling people to reach and maintain their optimal levels of both physical, emotional, and social function. There are also some evidence from qualitative research where they use interviews typically to collect data about the experiences of the patients who live with incurable cancer. And that tells us a little bit more richer information about why loss of function is such an important unmet need. And as you can see on these boxes, there are different aspects here that comes forward when they do these themes that comes forward when they do these qualitative studies. Several which probably many of you can relate to when you work with these patients. So yet in the palliative care setting, we see that, and we understand and we are curious about the concept of rehabilitation is still contentious. It's given low priority by governments and funders and the public, and it's also given less money. So I think sort of we can see that we need to have focus on this to establish and integrate effective models for rehabilitation within the palliative care. So what is rehabilitation? It is a process designed to help individuals achieve and maintain their best possible level of physical, emotional, psychological, and social functioning. It equips people with the tools they need to uphold their independence, make decisions for themselves, and participate meaningfully in their families and communities. And the goal of rehabilitation is to support individuals living as well as they can, despite their illness and symptoms. And as I said before, this should be done through this holistic model of care that sees the person in a broader context, but also not just their physical, but also their social and environmental surroundings are considered. So we know that rehabilitation is quite established for people with chronic conditions such as respiratory diseases, heart disease, and stroke, at least in Europe. And this is unfortunately but this is not the case for people living with incurable cancers, especially those. And despite strong evidence showing a clear need for and benefit from palliative care services, the access to integrated rehabilitation for people with incurable cancer remains under-resourced and variable. We also have evidence from exercise-based rehabilitation for cancer patients that are increasingly becoming standards of care. And when properly guided, exercise is effective and generally safe for all people living with cancer. However, there is a concern regarding that the evidence base is largely built on studies involving people with early stage cancer and often post-treatment. There are very few studies still with people living in the incurable palliative setting. And we know that there are problems with adherence and fatigue, and they are not likely to be included in studies. So there is an urgent need to rethink our approach about this integration of rehabilitation into the palliative care setting. And we strongly believe that we need to develop new innovative models to make rehabilitation both accessible and equitable. And they must be designed to meet the unique needs of people living with incurable cancer. So I want to make you aware of the WHO policy brief on integration of rehabilitation into palliative care services that was published in 2023. And it does recommend that palliative rehabilitation should be integrated into the cancer care pathway. And in this context, rehabilitation and palliative care services, and this is more fully described in the brief if you want to read, but they are traditionally organized around differing but complementary goals for care. So they might have parallel pathways, but there still are complementary aspects here for this as a potential for the integrated palliative rehabilitation. And palliative services typically orientate towards optimizing functional well-being and to minimize the contribution of declining function to suffering. And I think supporting this synergy will require extending the palliative care teams to include rehabilitation specialists, and so that the services have capacity and ability to assess and identify functional concerns and respond to the special needs of these patients. And the brief also challenges rehabilitation services to expand their scope. So it's not just the palliative care setting that needs to think differently. And they must recognize that optimizing subjective well-being is also a valid goal for rehabilitation, when minimizing disability might not be possible. So we need to acknowledge the fact that the burden of the disease is also related to time lived with disability, and not just the premature death. So, having given you this background, I'm proudly to present that I'm part of this wonderful group of people in the INSPIRE project. And having established this rationale for palliative rehabilitation, we will talk a little bit more about this INSPIRE project from now on. And we have this consortium of clinical researchers, methodologists, and citizens from across 7 partner European countries that are working together to test a model of palliative rehabilitation for adults with incurable cancer. It's funded by the Horizon Europe and the Innovative UK, and it aims to deliver a scalable model of rehabilitation for people in the palliative phase of illness that can be delivered in any setting. And we are in the 3rd year now, Joe, of the project. Am I right? 2nd, 3rd? Yeah, you will tell us more about it later. So what I will do first is to try to go a little into the depth of the first work we've done in the INSPIRE project. And that was the work package 1. And although it might seem that the rationale for palliative rehabilitation in cancer are quite logical, there's still a clear need to further knowledge and understand how it can be understood and implemented across health services. So in the INSPIRE project, it was initially crucial to ascertain the current integration of palliative rehabilitation in cancer, and particularly within the partnership countries in INSPIRE project. So you can see here the team at the Center of Crisis Psychology at the University of Bergen, and my college here, which is led by Professor Line Oldeboll, and we were responsible for doing the first package. We set out to do a comparative service analysis where we wanted to look at official documents and clinical practices concerning palliative rehabilitation to gain deeper understanding of this field to serve as a foundational step for the INSPIRE clinical trial. I will talk a little bit about that now. Yeah, that's the first package of total of 7, so there's lots of work to do in this project. So in this work package, we did a mixed method study, which means that we used both quantitative and qualitative methods. We included methods concurrently in the same study. We did divide the study into 3 sub-studies, and in the first one, we did a document analysis to gain insight into how palliative rehabilitation is described or reported in official documents. And this whole study included all the partnership countries that I showed you who were in the INSPIRE project. So we wanted them to identify official documents of relevance to cancer or palliative care and should be published by policymakers, charities, but also NGOs, so non-governmental organizations that we are familiar with in our field. And it can be any type of official document, but it should be the current publication. So there were no historic follow-up on this one. It's just a current situation. And in the second study, sub-study, we performed the semi-structured interviews to explore experiences from stakeholders in clinical practice. And the stakeholders were interviewed, and they were from each of the partnership countries. And we gathered at least 4 of them, interviews from 4 of them, and they should be from primary healthcare, specialist healthcare, could be oncology departments or hospice, or rehabilitation services. And they can also be from NGOs representing cancer patients and carers. But they needed to have proficient verbal English to participate. And in the third sub-study, we did an online survey. Then we wanted to assess the current clinical practice based on established indicators of integration. And these are identified in the literature and quite extensively in the palliative care literature. So we've sort of went into this knowledge base to sort of find what are the indicators to say that the palliative rehabilitation is actually integrated. So this was a survey that went out digitally, like online, sent to all the lead investigators who forwarded this survey to all their medical and nursing staff, physiotherapists, OTs, psychologists, anyone who they thought were relevant, and they could voluntarily respond. And to analyze all this data, we did a concurrent analysis where we sort of merged the data. Firstly, we independently did analysis on all 3 data sets, but then we merged them and compared and contrasted and synthesized the results, just to make the whole thing richer and trying to see if the knowledge from each of the studies could build on each other to make us understand a bit more. It did give us quite a rich data material to try to get depth to, and I won't be able to give you every detail in this short amount of time. So in this first sub-study, each country were responsible to identify relevant official documents in their respective countries, and we extracted data for the document analysis. And this exercise resulted in the identification of 23 documents, and the countries were instructed not to include more than 6. So it's not like a comprehensive, complete document analysis. We were trusting them to identify the policy documents and official documents that they meant were mostly relevant. So as you can see from the left, all of these documents and their objectives are listed in the published paper, which I will give you reference for later. I won't go into detail on that. The circle diagram shows you the distribution of the types of documents that we used. Mostly guidelines and national strategies and policies. And out of the 23 included documents, our analysis resulted in 12 documents that actually include the reports or describe rehabilitation in the context of palliative care. So if it didn't describe that, it wasn't included in the analysis. And all of the documents were read in full text and extracted, so to make sure we didn't leave anything out, being aware that palliative rehabilitation is is not defined or used as a term itself, so we needed to be broad here to be able to catch relevant text. So we used this text and we analyzed it thematically. So that emerged, the analysis resulted in themes that emerged from the document analysis from these 12 documents. And these themes that emerged were that needs and access to rehabilitation. It's about settings and responsible parties and essential services in these countries. It was about timing and care pathways. And it was about goals, interventions, and professionals involved. And it was also a little bit about research and future palliative rehabilitation. And this is a table that's in the publication, which is too much for me to explain like this. So I made a little summary of it to show you the main factors that came out of a final sort of synthesis of all the documents in the end for this sub-study. And we found that the concept of palliative rehabilitation in cancer appeared in just one document. Only one document actually used the term palliative rehabilitation and explained it and described it. The other ones did use other terms, or they did talk about it in the context, as you saw from the table. So rehabilitation and palliative care have separate care pathways, but there is some overlap in terms of the goals for this service, the timing of it, the organization, and the professional content. And the documents also show that allied health professionals and rehabilitation professionals are required in multidisciplinary teams if one wants to improve assessment of patient need and access to rehabilitation in palliative care. But this is actually what the documents say that you need to have to provide this service. Whether it's actually done in the countries is another story. So research on palliative rehabilitation of cancer patients is definitely lacking. There was very few countries that actually wrote about it. I think UK was one of them. So that was a very limited field in these documents. There's a lot of information here, I can appreciate that, but we are moving on to this second study where we actually interviewed stakeholders who are in this field of practice, and we had 22 people responding and wanted to be involved here from the different countries. And the central question for the semi-structured interview guide was, can you please describe how palliative cancer rehabilitation is integrated in clinical practice in your country? And participants were encouraged to share their experiences and perspectives freely. Subsequent questions inquired into definition of palliative rehabilitation, its status as an essential service, the access for patients, and optimal delivery methods. And the interviews were transcribed and analyzed, and 3 main themes emerged. Varied understanding and use of the term of palliative rehabilitation in cancer, consensus on intervention types and professionals involved, and that palliative rehabilitation in cancer in clinical practice is limited. And I'm showing you, it's a lot of material here, but I'm showing you a few quotes that I think said a lot about. This is the first theme, and the stakeholder here from Norway is saying, I think that rehabilitation is integrated in what we do in palliative care without putting it into words. For me, if you provide good palliative care, then it's not only symptom relief, but a very strong element of optimization of function. I think this says something that there is a common understanding of the main components in the division of cancer rehabilitation, but there's an unclear distinction between palliative rehabilitation and palliative care. But I think this also reflects that while one thinks one actually is doing rehabilitation, one thinks one is doing palliative rehabilitation because one is relieving symptoms. It's not actually maybe that you are actually optimizing function at the same time. I think this, in Norway at least, we saw that one thought we did actually do palliative rehabilitation, but maybe it's not what we are thinking of that should be. And the other themes, there were quotes from other stakeholders that says something about the components and that they should be based on the patient's needs and preferences. And when thinking about access, there was actually indications that access to palliative cancer rehabilitation is like a postcode lottery with challenges related to funding, care pathways, and education. So overall, the interviews show that although the policies can have description of what should be involved, there is actually quite limited integration of palliative rehabilitation in the clinical practice field. So the survey was also based on these indicators of the integration, which is about having a multidisciplinary team, following standardized care pathways, sharing records, doing educational activities, sorts of things like that. And in 22 questions, they could answer questions addressing palliative rehabilitation in their practice at their site. So these were sites that was involved in recruiting patients in the INSPIRE project. And 87% actually said they are working in multidisciplinary teams. And 35% said they had physiotherapists in their teams. So 71% were following standardized care pathways, and 56% shared the patient records, but only 12% shared them across the levels of care. And having multidisciplinary educational activities were reported by 67%, but only 9% had joint activities between palliative care and rehabilitation services. So that was different. Conducting routine assessments for rehabilitation need was reported by 44%. And the trigger factors for referral to rehabilitation for these patients were poor physical functioning, discharge to home, requests of patients or carers, or it was actually a part of the care pathway. And 25% did not refer patients with incurable cancer to rehabilitation at all. And when they were asked to respond to some statements, the following was given, and then the blue is they agree with the statement, and the red is that they disagree. And palliative care and palliative rehabilitation offer the same services. There was not many people who agreed to that, 25%, and quite a lot disagreed actually. Many were also unsure. They are not, the number is not here, but that's the rest of the 100%. And palliative care focuses on symptom palliation. That was quite a large portion of stakeholders that agree to that. Palliative rehabilitation focuses on physical function. Nearly 50% agree to that. Rehabilitation is most appropriate for curative cancer patients. People did not agree to large scale to that. People actually disagreed. So that's good indicator. And rehabilitation is not appropriate for cancer patients towards the end of life. People do not agree to that. They actually disagree to that. That also says something about the situation currently. So if I want to just sum up this, we found that integration of rehabilitation in cancer remains limited in official documents and clinical practice, despite the presence of some indicators of integration, especially maybe from the survey. Integration of the rehabilitation in cancer is primarily observed within specific organizations in secondary healthcare systems, and maybe Denmark and the UK were standing out there. However, there's no widespread adoption, evidence of no widespread adoption. And stakeholders recognize that effective implementation of rehabilitation in cancer should be multidimensional, and they should align to patients' needs and goals, emphasizing a holistic approach. An ambiguous distinction exists between palliative rehabilitation and existing palliative care as concepts. And this was quite, emerges from all of the sub-studies actually. And insufficient funding, lack of rehabilitation as part of care pathways, and competence deficiencies among healthcare professionals represent barriers for integration. So this is something we have published now, and you can find this publication on the internet. We have sort of concluded that there is a need to address these challenges if you want to ensure the continuity of care for people with incurable cancer. So we need some more robust evidence to support this action, and this is something that I'm very happy that Joe is going to tell us a little bit more about now. Joe, I think I've spent my time.
Thank you so much, Guru, for such a great start. I'm wondering actually whether I should share my screen so then I can see my notes. Would that, if you stop sharing and I'll start sharing and pick up from the slide? Yeah, that'd be great. Thank you. So I'll share my screen now, if I can find the presentation. Just give me 1 second. This one, I think. Then I go down to, can people see that now?
No.
No.
We see a black screen, and now we see something.
Do you see your presentation?
Yeah, but we need it to be full screen if possible.
Yeah, I'm trying to get it to go into presentation mode so I can see my notes. Is that, can you see it now?
Yeah, can you see your notes?
No,
Yes.
I can't see my notes, never mind. I've got another screen open with my notes on, so I will...
If you right click now on the presentation, you can go in presentation mode, but then we may probably see your notes as well. You need to sort of limit the frame.
Show present to view.
Yeah.
There you go. That's it, right. So you can't, can you
okay, we can't see your notes.
Great, you can just see the full screen. Great.
Yeah.
So this is good now. Okay, so this is the figure that Guru showed you a few minutes ago, and that she was presenting the data from work package 1, and I'm going to focus now mainly on work package 3, which is the main trial, but I'm also going to share a little bit of information about work package 2, which was how we got ready to deliver the intervention in the trial, and also work package 5, which is relating to how we delivered the intervention as inclusively and equitably as possible. So this talk, for the rest of this talk, we're going to be talking mostly about the pragmatic randomized control trial. And as Guru said, we wanted to develop a scalable intervention that had potential to be integrated into oncology services in any setting. We were already conscious that there was a postcode lottery in the UK delivering rehabilitation in palliative care, and we're a high-income country with a fully funded National Health Service, so if it's hard for us to deliver it equitably, then it's going to be hard everywhere else too. And so the intervention was theoretically informed. This is what I spent my PhD doing. I'd been working in clinical practice in a specialist palliative care unit in Liverpool in the north of England for 20 years. So I'd kind of got a lot of clinical experience about what patients and families seem to want when they were in the palliative phase of their illness. And then I spent time academically developing that and relating it to theory, that clinical experience, to develop this model of rehabilitation for people. Actually, in my PhD, it was for people with advanced lung cancer or mesothelioma. So the intervention is manualized and it's delivered over 3 sessions by an expert rehab practitioner. And I made it a rehabilitation practitioner rather than a physiotherapy intervention or an occupational therapy intervention, in recognition of the fact that not every health setting has physiotherapists and occupational therapists, but that rehabilitation competencies can be taught to other healthcare workers. So that was quite an important feature of the intervention when we started. And the intervention can be delivered in a range of settings, either in a health setting or in a person's home. And it contains 3 core components. And these aim to optimize symptom self-management, to optimize physical activities and fitness, and to optimize social participation. And a little bit more about the symptom self-management. As Guru said in the work package 1, many members of the palliative care team perceive that their medical and nursing interventions to manage symptoms will automatically then turn into an improvement in function. But what we find when we're working in palliative rehabilitation is that that is not necessarily the case. And people don't necessarily know how to translate improved pain management, for instance, into continuing with the activities that they want to manage, because they are afraid of pain coming back, or if it's breathlessness, they're afraid of making their breathlessness worse again. So we found that helping people to manage the impact of symptoms on their activities was a really crucial part of the intervention. And then the word fitness. We originally weren't going to put the word fitness in here. We're talking about people who are palliative, who may not have the time to actually improve the muscle bulk or muscle function. But actually the patients in our feasibility and development work really wanted to use the word fitness. And to them, fitness meant being able to cook a meal for my family, being able to take my daughter to school, fit to do the activities that they wanted to do. And we also know, because of all the exercise oncology research, that even in the palliative phase of illness, people can improve muscle function. And lastly, social participation. We recognise that for a lot of people, the stigma and the meaning and the fears associated with illness, never mind the symptoms and the changes in their physical capacity, meant that people were struggling to maintain the social roles and routines that were important to them. And sometimes it really helped them to have a thinking space to strategise how they can maintain their social participation. And we tested this intervention in a feasibility trial, and I have to say, people were quite sceptical about whether patients would want to participate. One person in our ethics committee actually asked us, are we raising false hope, offering rehabilitation for people with incurable lung cancer? But despite their pessimism, we were able to achieve our feasibility aims. We were able to recruit people with incurable lung cancer onto the trial, and they stayed on trial long enough to collect the outcomes data, which you need if you're going to test an intervention in a trial. And the outcomes measures that we selected appeared to be relevant to their needs and demonstrated clear use for to use them in an effectiveness trial. We also had high levels of intervention fidelity and high levels of participant satisfaction with both the intervention and the trial processes. And the changes in the clinical outcomes were most apparent for health-related quality of life, which surprised us, because quality of life can be a slippery concept. Even if you can improve somebody's functioning, they're still living with a life-limiting illness. And you may not improve their overall quality of life. But nevertheless, that was the measure that showed the most change. So then with the consortium that we developed, which Guru described, with all the methodologists and researchers and clinicians across these 6 European countries, we put together and refined the intervention for testing in an effectiveness trial. It's an international phase 3 multi-centre parallel group randomised controlled assessor blind superiority trial, for those of you who are into your trial methodology. And we're testing palliative rehabilitation plus usual care versus usual care only. And our sample size that we're aiming to reach is 340 with 117 each arm, and that will give us statistical power to check a difference in FACT-G between the 2 arms. Participants stay on the trial for a maximum duration of 16 weeks, although we also collect survival data at 28 weeks. And the overall trial duration is going to be around 24 months, although we might be extending it a little bit. And we're currently testing it in 11 sites in 6 European countries, which is Norway, Denmark, Italy, France, Czech Republic, and the UK. And we have a broad eligibility criteria deliberately. We include any incurable solid tumour. We are excluding haematological cancers because they have a different disease trajectory, and also haematological oncology services tend to hold on to their patients and not integrate with palliative care as well as other solid tumour groups do. Participants can be receiving simple rehabilitation when they enter the trial. So they might have been seen by a physiotherapist for a walking stick, or by an occupational therapist for some discharge planning. But an exclusion criteria is that they mustn't be receiving goal-orientated specialist multimodal cancer rehab. Patients who are already receiving specialist cancer rehab are excluded from the trial. Likewise, the participants need to have a clinician-assessed prognosis of greater than 3 months, because we want them to be well enough to complete the outcome measures at baseline, 4 weeks, 8 weeks, and 16 weeks. Our primary endpoint, like I said, is quality of life at 8 weeks, measured by FACT-G, and you can read a protocol of the trial and the whole project actually in this paper here, which we got a QR code for at the end of the presentation. So participants are randomised in a one-to-one allocation, and our secondary outcomes measure quality of life subscales. We're using the WHO-DAS measure to measure disability, IPOS to measure symptoms, and we're also using goal attainment scaling. We're evaluating the cost effectiveness of the intervention, and we're also measuring implementation outcomes and equity and inclusion outcomes. So intervention readiness, we needed to get all the sites ready to deliver this intervention. And as I've already described, it's a complex intervention with 3 quite broad components: symptom self-management, optimizing physical activity and fitness, and social participation. So it's not that every patient gets exactly the same intervention, but they get the same principles. The focus is the same across all sites. And that was what we needed to get all the rehabilitation practitioners at all the sites ready to deliver. So we generated an intervention manual, which teaches people how to do the assessment, how to set goals, how to incorporate behaviour change techniques, and also how to deliver the core components, how to manage the different symptoms, how to optimise physical activity, and how to optimise social participation. We prepared training materials. We prepared asynchronous narrated PowerPoint presentations, which were available to all the rehab practitioners to watch, to rewatch, to slow down, to stop and pause. And we also had an in-person one-day training session for all the rehabilitation participants. And at each of those training sessions, there were members of their usual healthcare team present who could help with translation during the training. And all the intervention manuals and rehabilitation data collection booklets were translated as needed in the partner countries. We also have arranged a monthly community of practice for rehabilitation practitioners, which we've had probably 8 meetings now throughout the trial, where the rehabilitation practitioners come together and share how it's going delivering the intervention in the trial, how they're managing to deliver the different components, challenges that are arising. And this is helping to ensure that we are delivering the intervention with fidelity. Rehab practitioners prepare mini case studies which demonstrate how they are assessing all the patient's needs, how it's person-centred and tailored, how they are using goal setting, how they're incorporating behaviour change techniques, and how they're developing the onward plan, because a key component of the intervention, which I haven't mentioned actually, is onward signposting and referral for onward support. And this is key because not everybody with incurable cancer is the same. They're an extremely heterogeneous population. As Guru said, some people are elderly with multiple comorbidities and have already slowed down considerably and let go of some of their routines and activities. Other people with advanced incurable cancer are young, they're trying to work, they have a family, they have responsibilities. So the 3 sessions enables us to really tailor the needs of that individual person and then refer on and target them to existing rehabilitation services, sometimes in the local community. For some people, it's just having the confidence to manage on their own at the end of the Inspire intervention. And at each site, we get the rehab practitioner to identify the local resources, the information resources and local services that participants can be referred on to. And we're capturing that data in our trial outcomes. And this is just a few of the goals that participants have set during the intervention, which demonstrate that the core components are being utilised. So, for instance, to be able to get out of bed and sit in a chair to sow seeds in pots within a month. So there's quite a lot involved there. It was in managing the symptom, which in this case was pain, to help the person with an efficient movement and the right amount of support to get out of bed, and then a comfortable chair to sit in to do a meaningful activity. And actually, the person who set this goal progressed beyond this. And I think at the when they were checked after the intervention, they were even getting out and going on the bus to locations in their local community. So they exceeded their goals. Another participant wanted just to cook a meal with their family, and they'd got a new perching stool, and it was helping them to sequence movements and to sequence activities and to maybe cook a meal in a way that's different to how they would normally do it, so that they were able to achieve the goal. And then somebody else wanted to go out to a local hall with husbands and friends and required a wheelchair to achieve that. Somebody else wanted to walk more steadily around the house, which might involve breathlessness management and some strengthening, maybe a walking aid. And to be able to iron with less pain in her arm and shoulder. So again, creating the situation with the ironing board and a chair. And also in this case, they adjusted the handle on the iron so the person could grip the iron. I'm not sure how many people would have ironing as a goal, but for this lady, it was very important. And actually it was her second goal. Her first goal was that she wanted to have a new purpose in her life. And the rehab practitioner identified that she'd previously enjoyed painting and writing poetry. And her first goal was to write a poem or create a painting, which kind of expressed how she felt about participating in the Inspire trial. And she did write the most beautiful poem, which I'm not able to share with you today, but I think that shows the range of the intervention, that it involved altering the handle on an iron, but also giving the person the confidence to get back into writing their poetry again. Research equity and inclusion is really important to us, and from the get-go we wanted to make sure that all participants in our catchment areas had potential to join the trial. And many of you will be aware that much clinical trial literature recruits highly educated middle-class people, mostly white people, and we wanted to make sure that we understood our local communities and the barriers to inclusion in trials that might be there in our local communities, the knowledge that we've had from running previous trials. And we established strategies and using a template that was delivered to us by our Danish partners. And we've had regular meetings to ensure that we're still meeting our inclusion strategies. So, for instance, in London, we've used translators twice to support delivery of the intervention and the completion of the outcome measures, so that participants have somebody to help them understand, even though they speak English, to help them with the nuances of meaning. And we've also made efforts to arrange to be able to deliver the intervention later in the day when a participant's daughter or son is home from work and can support them during the intervention. And our Danish partners held a World Cafe with all the researchers involved in the project a few weeks ago in Denmark, and they're going to be summarising that data in the very near future. We're open to recruitment, like I said, at 12 sites, and up to yesterday, we'd recruited 217 out of our 340 participants. So we're well on the way to achieving our target, and there's researchers at all the different sites are doing an extremely good job of recruiting to their targets. Sorry, nearly at the last slide. We're going to disseminate the findings from late 2026 following final analysis. But in the meantime, we do have a website. Please stay connected and share your thoughts. What do you think about this intervention? Does the intervention address the concerns of people living in your community, your neighbourhoods? What's missing? When you heard me speaking about the intervention, what would be difficult to deliver in your setting, and how might it need to be adapted? We're going to be doing another work package where we're going to be coming together to pull together evidence and a consensus statements around rehabilitation and palliative care. And that's something that you may be able to be involved in. So please do keep in touch. Even if it's effective, it may not be effective everywhere. So our take-home messages and where to find out more. Palliative rehabilitation and Inspire aim to optimise function, social participation and agency in incurable illness. We want to reduce the suffering that's related to changes in loss of function and support people to remain at home, and to reduce the impact of costs on health, social and informal care. So thank you for your attention, and I think in the previous slide, I'll come back to this one because it's got the QR codes, but just so you can see here the logos from all the different partner sites and all the different countries. And these are the number of people that are involved and more. Not everybody was able to get to the meetings, but a huge number of people involved in delivering a trial of this scale. And I'll leave that slide up so you can get the QR codes for the rehab, the policy brief from the World Health Organization and for the Inspire website. Thank you for your time.
Wow, thank you. Thank you very much, Guru and Joe. I think thank you for sharing your impressive and thorough work and presenting the Inspire project in a very inspiring way. I think this is a good time to answer some questions. So I think if we look at the questions we had on the chat, they ask for the presentation as well. I mean, this presentation is recorded, but is it possible to get the presentation, or do you prefer them just taking the screenshots for the QR codes?
Yeah, I think most of the information is on the website. There's a lot of information on the website. We've shared, we've written blogs, we've commented on other palliative rehabilitation literature. So most of the meaning that we've presented today can be found on the website. I'd be happy for PDFs to be shared of the slides. I don't know about Guru.
Yeah, that's fine.
Yeah. And I think there's a question from Charlotte in Belgium. Yes, we can deliver the intervention in the person's home. I think it might be quite difficult within 30 minutes. I think some participants, especially participants with lower levels of health literacy or who've got more symptoms, require most of the interventions last at least an hour, sometimes 90 minutes. We tend not to go on longer than that because people are tired, and we'd rather split the intervention over the 3 sessions, over the 3 intervention sessions, which can all be around an hour. And what we find in practice is that some people want to have their second and third interventions quite close together so they can really integrate the learning from the intervention, and others want a longer gap. They want a couple of weeks between interventions to practice things before they have their next session. But yes, we can deliver it in the home. It's designed to be delivered in the home. In fact, I would say it's probably better delivered in the home because then you can really relate it to their environment.
Okay, are there any other questions? You can just open your mic and ask.
Where the UK bases are, okay, the UK bases, we're recruiting at King's College Hospital, Guy's and St Thomas's Hospital, York Community Palliative Services and Scarborough Palliative Community Services in Yorkshire, and also in Edinburgh. That's where we're recruiting in the UK.
Okay. I'm asking because I actually work in a small community team, and we have we've got palliative, we're a palliative team. And we've started doing palliative exercise therapy, incorporating hospice, gym with exercise physiologist and home-based to kind of move between us, because we were recognising there was absolutely nothing on our local area, and based it on the CAN rehab principles, which obviously is based more on cancer rehab, but not on palliative. So I'm kind of intrigued to hear about this going, it looks like I'm kind of doing that in my own little small scale without realising.
You probably are. You probably are, Helen, because I felt like I was delivering it in the hospice in Liverpool for 20 years, but it's no evidence. And so it remains ad hoc. And we do use exercise within the Inspire intervention. So many of the participants will be getting an exercise prescription, and we'll use existing exercise resources that are appropriate to them. So sometimes we use the Charter Society of Physiotherapy Get Up and Go. Other times we might use Macmillan. We might use oncology centre websites, depending what's available locally. However, we find that a lot of participants, when we do goal-orientated rehabilitation, they want more than exercise. They also need symptom self-management strategies and goals, help to understand different strategies of moving and organising their weeks and structuring their weeks, and giving them permission to do the things that are important to them and to let go of the things that aren't. So yes, we incorporate exercise, but it's much more than exercise. But I'm glad you probably are. And if you were able to read the manual, you'd probably say to yourself, I'm already doing that. Yeah.
So is the manual accessible online?
It will be after the trial. We're going to
Okay.
disseminate after the trial, but obviously during the trial, because of contamination, we have to keep it. We have to keep it within the trial during the trial. But we've got a big dissemination package, and whether the trial's effective or not, we will be disseminating the training and the intervention manual. And yeah, so watch this. Keep an eye on the website. But I can assure you that there's probably very little in it that you're not already used to doing. I think the expertise in palliative rehabilitation is that ability to be present with the person, and it's that balance about whether somebody is recovering or declining. And sometimes they can be recovering in some areas while something else is declining, but and fundamentally at the end, we're supporting decline. And that's what sets palliative rehabilitation, I think, apart from traditional general rehabilitation, where a lot of services, somebody has to have potential to benefit from rehab and i.e. recover to be admitted into the service. So whereas we think people can benefit from rehab even if they're not able to recover. So what sets the manual a bit apart, I think.
Yeah, cool. Thank you for the time, and thank you for all of the work across all of you.
Oh, thank you, Helen. Thank you. I'd love to know where you're working, so do get in touch. And Ryo, a physical therapist from Japan. The intervention used by research is currently not covered by our national health insurance system in the UK. If you go to a really good hospice like the way where Helen is currently working, who's just been speaking, you probably would get a large amount of our intervention, but it would depend on where you lived. It's not routinely provided. Hopefully it will be if we get some positive evidence. That's a really good question, Charlotte. I don't think it is necessary to have a background in psychology, but I do think it's important to be able to deliver rehabilitation in a psychologically informed manner. So all of us who are experts in palliative rehabilitation will have received training in kind of existential.
We have to go.
I love all the kids that are around today. Yeah, so many of us have had, training in kind of solution focused therapy, spiritual support, spiritual care. So it's really important. But I think often patients find it easier to talk around their psychological and spiritual issues in the middle of a session focused on their functioning. It can be things like something about I'm struggling to get upstairs to go to bed. Well, how much effort do you want to put in how important is it to you to be able to sleep upstairs in your own bed? And that can bring in a lot of issues around meaning, be able to sleep next to their partner. Some people want to work quite hard to be able to carry on getting upstairs. Other people, no, just bring the bed downstairs. I don't need to be upstairs anymore. But that's the bad news for people not being able to get upstairs into their own bed to sleep next to their loved one who they've been married to for many years. Can be very distressing. So we have to have the ability to handle the kind of losses, the meaning, accepting a walking aid when you're in your 50s to help you walk. Walking aids are for old people, so we're often dealing with loss and the psychological consequences of changes in functional status. So yeah, I would say any palliative rehabilitation specialist would need to ensure that they had psychological competencies to deliver the interventions. Good question.
I agree. That's a very nice answer. Thank you.
Davidson? Guru, have you got any? I'm just taking the floor. Guru, have you got anything to add?
That's okay, Joe. That's okay. No, I just really wish people to reach out if they have knowledge, experience from their countries. That goes also to the work we've done in the work package 1, where we try to understand the field and the knowledge and the current status, which is like limited to the countries within Inspire at the moment. But I think it's really interesting to hear not just Europe, but as well, and other experiences around this in their practices, and also what type of documents. So I would so happy if anyone wanted to send me an email about these things to enrich us even further in our understanding, and maybe the work from Work Package 1 can expand, Joe, to something in the future, covering more than just these sites.
Yeah.
But thank you very much, everyone, for contributing with your questions. It's really, I love this. Yeah, thank you.
Yes, so unless Davidson, you have any other questions to ask here? Oh, here you are.
Oh, really, as someone, I'm excited at the depth of the presentation and the quality of the work done. And I know that we in the global south, low MICs, we have some challenges, and this may be a very good work to be adapted and contextualized, in our setting. And if there is any more program or project by Inspire, we would like to collaborate so that global south experiences will also be made prominent, at the global level when we're talking about palliative care in cancer and other ailments. So thank you. But we're open for collaboration,
Yeah.
inclusivity of South. Thank you.
Yeah, and we're very keen for that, Davidson. Again, like I said at the beginning, the way that we've designed the intervention is so that it can be kind of adapted and is a low resource, hopefully a low resource intervention. I mean, in the Inspire trial, all the rehab practitioners are physiotherapists and occupational therapists, but the way it's designed would be so that you could have, community health workers trained to deliver the intervention. As Charlotte said, within the intervention, we do look at the psychological issues as well as the more traditional rehab issues. So I think learning how we could adapt this intervention to different cultures and different contexts is something that the Inspire project team are all very interested in. I think Guru would agree with me on that. So yeah, we'll look forward to collaborations.
And I'm also pleased that social participation was included, in one of that contributed, because sometimes we just focus on intervention and function without looking at social participation and the integration. So yeah. I'm very pleased about that. It's good.
Yeah. And I have to say, some of the goals, I mean, I couldn't put all the goals up, but some of the goals are things like being able to go back to my choir or being able to carry and get into the mosque. It is really focused, and the intervention strategies are very, very focused on things that matter to the person. And I think that's what's really special about the Inspire intervention. And if we can capture that in our publications, then I think that will help different sites across the global south and high-income countries to find ways of integrating the rehabilitation intervention into palliative care services.
Okay.
Thank you very much.
Yes, thank you. So once again, thank you very much, Guru and Joe. You did a wonderful job. We really appreciate, and I hope that we have more collaboration. So thank you for presenting here, and have a good rest of your weekend.
Thank you.
Thank you so much.
Thank you for having us. Thank you.
Thanks for the attention.
Thank you.